We're going to talk about renal. So we'll talk also about catheter-associated infections again. So we're like killing this. You know, you're going to get it in both places. Some people emailed me like, oh, where do I find this and what chapter? It's very hard to say certain chapters because it's repeated in a lot of chapters. You know, you'll see it in a lot of places, not just one. All right. All righty. So these are your organs in the renal and urinary system. You have your structures of your kidney. You guys learned this with Dr. George, I believe, if that's who you had for anatomy. Your anatomy of a nephron. We know that with, we know that over here in the Bowman's capsule, in the efferent areola and the distal convoluted tube, that these cells produce renin, which helps regulate blood flow. Glaucarium, I can't even say the word, filtration, rate, and blood pressure. So you know that if a patient comes in, and you guys learned this last semester with cardiac, okay? I know Professor Corrado has killed you guys with cardiac. No, I'm not going to kill you with it. But just always remember that if something goes wrong in somebody's heart, okay, the next organ to usually go is the kidney. All right. Same thing, vice versa. So if they have a kidney problem, you can expect the first organ to go after that is the heart. Okay. Because they're like brother and sister. They work together. All right. So your renal tubules, this is where most of the absorption happens. These maintain fluid and electrolyte balances. Remember, we're not talking about peds. We're more talking about the older adult, the middle-aged adult, okay, and then getting older. So they have cortical tissue loss, smaller nephrons, their blood flows to the kidney declines, they have decreased GFR, they have nocturia, okay, hence why they gain this incontinence, decreased bladder capacity, weakened urinary sphincters, and shortened urethra in women, okay? And you will see this, guys. You guys are learning about that woman in OB, okay, that is going through a natural birth, okay? After that, those sphincters, they start to weaken, especially multiple pregnancies. And the tendency to retain urine. It can be like a thing where the woman knows and she's working all day, or the person, they're busy and they can't use the bathroom, or they just don't have that urge to go, okay? We will do a history on our patients. I'm sorry, I feel like I'm all over the place. We will do a history on these patients. So demographic information, you'll look at their age, gender, race, ethnicity, and if they have a sudden onset of hypertension at the age of 50. The social economic status is their level of education, their beliefs, their nutrition history. You're going to ask them about recent dietary changes. How much do they drink in a day? Okay. Some patients will come, and it happens all the time. They come to the ED and they're like, listen, I haven't peed, I'm having a problem with peeing. And you ask them how much you drink. Well, I had a coffee this morning. Well, did you have any water? They're severely dehydrated after that. Their body doesn't know what it's like to drink anything. So they can maintain, but they don't have no output at that point. They have a risk for renal calculi if they have a high protein diet, okay? So patients will come in, let's say they're on, what is that, keto? Am I saying this right, keto? Where they do that high fat, no carb diet with high proteins. These patients are at risk for renal calculi. They'll get a stone because of all that protein that they're taking in. So you got to be very careful with that. Family history and genetic risk, and current health problems. So you want to ask about any drugs for hypertension or diabetes. We also want to know, were they recently prescribed any antibiotics? Okay, so we know you guys learned in pharm, any antibiotics like gentamicin can put that patient in acute kidney injury. All right, so you got to be very careful. A lot of the drugs today, especially like the antifungals and stuff that they take by mouth, the doctor will usually have the patient go for a CBC and a CMP beforehand to make sure they look at their kidney function, okay? They don't want to give the patient a drug where they can put them in kidney failure. So you got to be very careful with that. You want to ask about elimination, okay? How often do they go? Do they have periods of incontinence, okay? Sometimes they'll start off and tell you like, oh, I walk around with it depends, God forbid I have an accident. But it's led me to now I I don't feel that I'm going, and I just urinate. I pee myself. Women who have a shorter urethra, so they most likely will develop cystitis. So now you're going to do your physical assessment. So you ask them the questions. Remember, you want to ask first in this case, not start feeling around. And then you're going to look at the general appearance. So you're going to inspect the abdomen, auscultate, listen in that area, observe for symmetry. You want to listen for a bruit over each renal artery. Kidney palpitation is performed by the doctor or the advanced practice nurse. So remember, if anybody asks you to do that, it's not part of your scope, okay? Advanced practice nurse, totally different.
That's for all palpation?
Yeah. If they have flank pain, you want to do, let's say they have flank pain on their right side. You want to do the left side first and then go to the painful side. You're not going to go to the painful side, touch the painful side, because what's going to happen? They're not going to even let you touch the rest of their body. You're going to look at their skin, their kidneys, urethra, and bladder. Their urethra, you're going to use good light. So, you want to have your pen light, or if they have those lights. A lot of places that we put the patient in like lithotomy position, and we look very good with those big lights that come up, okay? Record any unusual discharge. You're going to inspect the skin in that area, okay? Especially if they're incontinent, okay? What does urine do to the skin? Breaks it down, okay? So if they keep in these periods of incontinence, their skin is not going to look too hot. They're going to have rashes. It's going to be red. Maybe try telling them to put like an A&D or an Aquaphor over it, like a barrier over that skin. You want to use this opportunity to remind women wipe on how to wipe from front to back. Psychosocial, it's an uncomfortable feeling, it's an uncomfortable, so we just want a lot of reassurance to these patients. If they have a distended bladder, how would it sound? Dull, right. Very good.
Who was that, Gerard?
Yeah.
He started reading the chapter.
Oh, I love that for him. All right, lab assessment. So blood tests is found on 1313, and urine test is 1314. So we're going to look, when we look at the blood test, you're going to look at the creatinine, which is produced when the muscles and other proteins are broken down. The BUN measures the excretion of waste from kidneys. So an elevation in the BUN does not always mean that the patient is an acute kidney injury, okay? Has to go hand in hand with something. So if you just see that BUN is elevated, don't automatically think the patient's in kidney failure or something like that. You're thinking something else, maybe they're dehydrated or something. An elevation in BUN and creatinine can suggest, see how they go together, suggests is some kind of kidney dysfunction. You have something, it's called on the blood test cystatin C, and this measures that GFR.
What is it called?
Cystatin, cystatin -C.
Measures the GFR.
Measures your GFR. Your urine test, so you have a UA. Everybody's used to that. Patient comes in, we give them a little cup, we ask them to urinate. What happens if the patient can't urinate?
We give them water?
Well, yeah, you're going to give them water. But no, I'm saying, let's say this patient is incontinent and they don't know when they're going to go. We're going to straight catheterize them. Can you straight catheterize them on your own? No. You need an order. You can straight catheter them on their own, but you need a doctor's order to do that, okay? You don't want to just go, it's an invasive procedure. It's invasive. So you need a doctor's order to say, okay, to straight cath patient. Of course, yeah, 100%. You're going to bladder scan them. Has everybody seen a bladder scanner in the hospital? Yeah. Has anybody not? Not? No? So a bladder scanner, it literally looks like an ultrasound. You go right over the bladder with some gel, and you press the button and it will scan the bladder and tell you how much urine is left in the bladder. So a lot of times when we take out a Foley catheter, after 6 hours, if the patient can't urinate, we'll bladder scan them to see. Anything usually over 200, the doctor will say, put a Foley catheter in, okay? If it's, because at that point, anything over 200, we usually have the urge to pee, to urinate, pee. Let's see. Hold on, I'm getting there. So our urine test, we'll look at our UA, our specific gravity, our KUB. That is an x-ray, okay? It's done bedside. The KUB stands for kidneys, urethra, and bladder, all right? They can do this bedside, so there is no special prep for it. They come at the bedside a lot of times. They're just going to tell you to get out of the room so they can take this x-ray. The CT is three-dimensional, okay? They can use contrast. If your patient, listen to this, if your patient has a history of diabetes, okay, and is taking metformin, all right, they have to stop taking metformin at least 24 hours, like to 48 hours beforehand, because with that contrast, it could put them in renal failure.
All right. Say that, so the CT three-dimensional
with test. Yeah, so if they use contrast and your patient is a diabetic and they are taking metformin, they have to stop 24 to 48 hours beforehand, because if they don't, that contrast can put them in renal failure and they'll need hemodialysis, the whole 9 yards, okay? That is why a lot of times when the patients come to the hospital, they're immediately taken off their oral medications and put on insulin right then and there, and they get mad. They're like, wait, why are you doing a finger stick? Why am I getting insulin? I don't take insulin at home. In the event that they need a CAT scan, we don't want to wait. We want to just give them the CAT scan. So by giving them the insulin is safe with the contrast, whereas the metformin is not. So we need to stop it at least 24 hours beforehand. MRI looks at abnormal tissues. Your ultrasound. So if they were going to do an ultrasound of the bladder, remember, it requires a full bladder. All right, so sometimes the patient will be like, hold on, I'm going to go to the bathroom. No. Stay with we need to see what we're looking at, okay? So a full bladder. And then after it's done, they can urinate. Sometimes what they'll do, if they need to see like a voiding cystogram or something like that, we'll talk more about that. They will have the patient start with a full bladder, and then as the bladder is emptying, they'll take pictures, okay? We have our renal scan, which detects blockages in large arteries, and our renal arteriography. This looks at the size of the vessels.
Renal scan detects blockages in large arteries?
Yes. Just know that if a patient with creatinine, they will have creatinine clearance, which measures the GFR and their kidney function. So that is a whole panel that we do just specifically for that patient. Diagnostic assessment, more of it. So you have your cystoscopy and your cystourethroskopy. This evaluates the bladder, urethra, and lower portions of the ureter. It's given with general or local anesthesia. The patient is MPO at midnight. These patients need a bowel prep, okay? So they may give them a Go Lightly or some kind of maybe Ducalax for them to get that bowel prep to clean out their bowel. Post-cystoscopy, you're going to monitor for bladder puncture. So any bleeding, urine like that's discolored. You're going to monitor the vital signs, and you're going to call the doctor if there's a lot of blood, okay? Little trickles of blood, okay, but a lot of blood in that area, you have to call the doctor for that. Next one, cystography. This is where they insertion of contrast medium. It's a radiopathic medium. So anything you think of radiopathic, think of it, these patients, it like glows. You know, as soon as it goes in, it lights up.
What's it called?
Radiopathic. So these patients are going to need a urinary catheter at first, okay? Because that's how they put the contrast in. So after filling the bladder, they will fill the bladder with this contrast, and then they will take pictures as the bladder is emptying. So x-rays are taken during and voiding. Post cystography, you want to encourage the patient to have fluids, okay? These are the patients that you really want to watch to make sure that they're really taking in all the water. You can't just leave the water pitcher there and walk away for 10 hours, okay? We want to make sure that they're really taking in, they should be asking you for more and more water to like dilute it. Retrograde procedures, so we have a parallelogram and a cystogram. So this is an exam where contrast does not enter the bloodstream, so they will go in and they will evaluate the effectiveness of that organ. A retrograde. You have urodynamic studies. These test bladder capacity, tone, and urine flow. So if let's say a patient comes in, right, and this happens with the aging, we just talked about this. They're like, listen, like I can't feel that I'm going. I just go, well, I'm peeing myself, and literally, it's something that is very common. They will do urodynamic studies on these patients, okay, to see maybe it's the muscle sphincters, things like that.
It's used for patients that are like incontinent.
Yes. Kidney biopsy. It's usually done. They'll be given maybe a little general, okay. It depends on where it's done. If it's sometimes I've seen doctors do it in office, believe it or not, and then I've seen them do it in like an ambulatory suite. If it's done like in the hospital ambulatory suite, the patients usually MPO the night before to come in for the biopsy. It's very quick, very, very quick, but it takes them longer to go under than it takes for the doctor to do it. Like it's a very quick procedure. Once they go under and they get the biopsy of the kidney, it's sent to cytology, and then it comes back, whatever's going on with the patient. And that is 60.